So I'm going to start off with 8 sort of teaching points. We'll try to cram 8 points into 15 minutes here, but we're going to start with the most dry point. I know this isn't very interesting, but I think semantics is important. So when patients come into the office and I have to counsel them on Blount's disease, I always feel weird about saying disease because it makes it sound really awful. And I'm not sure why we use that term, maybe condition, disorder, syndrome, some other term might be better. But if you actually look up the definition of the word disease, it's a disorder of structure that has a known cause and a distinctive group of symptoms, signs, or anatomic changes. So maybe Blount's disease is actually the accurate term, but I didn't really realize that before. I think that it's important to distinguish the fact that early onset Blount's disease and late onset Blount's disease share the same name, but they're actually very distinct entities, even though they both produce varus. So we'll quickly run through that. So early onset typically on average involves females with bilateral disease, whereas late onset are males with unilateral disease. Early onset typically has more severe deformity, especially in the sagittal plane. Early onset has changes to the medial proximal tibial physis. So there's this downsloping, there can be physeal bar formation. And you never see that in the late onset Blount disease patients. There's never been a need for a hemiplateau elevation in the late onset group. The varus in the early onset group really only happens in the proximal tibia, whereas late onset typically gets varus both in the femur and in the proximal tibia. The early onset group can get compensatory distal femoral valgus, so that's different. And the late onset group can get distal tibial compensatory valgus. Typically, one of the treatment strategies for early onset, and this is a little controversial, but bracing is an option for early onset, whereas late onset